Okay, this is Dr. Ezi, and this is the 5th session of the critical care station abdominal aortic aneurysm. And now in this session, finally, this is the end of the station. They are going to ask you questions about this. This is a common station in the MRCS Part B, so let us go on. So, they are going to ask you the first question. Nobody will ask you about the diameters, and this is in Part A. Here, they are going to ask you about the complications of abdominal aortic aneurysm. Okay, someone who has an abdominal aortic aneurysm with a diameter of 6.5 centimeters. What are the complications? So, number one, we start from the least dangerous and then we will go up. So, first of all, a thrombus may develop there, thrombosis. And an embolism may rush from there and cause lower limb ischemia through the iliac arteries, right? Okay. Let's go to the second complication. Pressure effect on the surrounding structures. Because it is big, there are many structures there, it will occupy space. Okay. Number 3, what may get? Fistulation with the bowel. This may cause something called aortoenteric fistula with the vena cava, aortocaval, with the renal vein, aorto whatever. Okay, so fistulation may occur due to that. Okay, what may occur else? It may rupture. Right? If he is lucky or she is lucky, he may be treated fast, urgently. If not, death is a disastrous complication. Okay, so these are the complications of abdominal aortic aneurysm in general. Okay, let us go to the next question. They are going to ask you about the post-op complications. What are the post-op? This patient is treated surgically. Okay, and you know that he had either if it ruptured or not ruptured. These are the post-operative complications for this patient. Okay, so you want to mention the complications in general. Okay, for this case here. I'm sorry. So, okay. Well, so what are the complications that may occur post-operatively? A delayed rupture may occur in case that it did not rupture yet. Okay, if it ruptured or not, there may be, you know that they put a graft inside and some blockage for some arteries occur, and they try to relieve the aortic wall by letting the blood passing through this graft. Okay, so malposition of the graft, may occur. Okay, well, what may occur else? Arterial dissection. The blood may move through the wall of the artery and dissection may occur, aortic dissection. And this is also a fatal complication that increases the mortality rate by 1% with every hour passes with the dissection. Okay. Okay, what else? A leak may occur, endoleak or leak may happen. Okay, we are going to go to another page, 5. Iliac arteries rupture. This is a complication, post-op. Okay, what may occur also? Ischemia to the spinal cord. Okay, what else? ischemia to everywhere, to the kidneys, to the liver, to the bowel. Okay? Hey, what may occurs? If it is to the kidney, acute renal failure may occur, right? 9, congestive cardiac failure may ensue. Okay? So all these are complications that may occur post-operatively. Okay? Well, what is the next and the last question in this station? They will ask you about the management. How will you manage this patient if he had a ruptured abdominal aortic aneurysm? What are you going to do? This patient, his abdominal aortic aneurysm now ruptured. It has ruptured already. What are you going to do? The usual answer in these cases, I'm going to treat this patient according to the A, B, C protocol, right? Let us go. So, A, you are checking the airway and you are giving high flow oxygen. Finished. B, breathing is fine. It is okay. So, most of your work will be in the C. Because this is a ruptured aortic aneurysm, you have bleeding. Circulation is now dropping down. So, most of your work will be in the circulation. So, what are you going to do in the circulation? Number one, the first thing you are going to do is that you are going to insert large bore cannulae, okay, in both antecubital fossa. Okay. Well, what are you going to do next? You are going to give IV fluids, right? But you are going to give that cautiously. Okay? Why? Because you do not want the pressure to be, the systolic blood pressure should not be above 90 to 100 mmHg or millimeter mercury. Okay? Why? Because as you increase the pressure, as we mentioned before, you increase the pressure, he will bleed more. So you are going to keep the circulation, but not more than this pressure. Okay? Well, what are you going to do in this here now? You are going to insert a urinary cath. Why? Because you are going to measure the urinary output. Because this is the most sensitive way by which you can have an idea about the perfusion of the organs, right? Okay. You are going to give analgesics. Actually, this is not directly related to the C, but you are going to give analgesics here, okay? And as you are stabilizing the patient here, okay, you are going to start your blood works. So, we are still in the C here, okay? We finished the C actually, and we are going to the, we are going to the investigations, right? Okay, you are going to, number one, doing cross matching, grouping cross matching, matching, I think this is wrong, but anyway. Group and cross match at least 10 units of packed RBCs, at least 4 units of fresh frozen plasma, okay, and get ready because this patient may have a complete rupture and everything will go catastrophic, so you should get ready. If you are going to the theater or not, you should do that. So you are going to do full blood count, you are going to do chemistry, urea and electrolytes. You are going to do, as usual, this is a critical case, you are going to do liver function tests, all. You are going to do glucose or blood sugar. You are going to make a coagulation profile here. It's up to this actually, but let us put it here. Coagulation profile. Okay, you are going to do everything here. Okay, so what are you going to do next? You are going to, this is a very important point, contact your senior. Okay, you want to involve the vascular. This is the first step, number one, because you do not want him to get angry. Okay, vascular surgeon. Okay, if there is a possibility to take that patient directly to the OR, you are going to contact the anesthetist and the theater staff. Okay, well, and finally, it is an important step, but most of the people forget it. You are going to discuss, sorry, I will write it in another page. You are going to discuss with the family. Very important point. And if you say it, actually, the examiner would be so happy with you. Believe me. Okay? So this station has finished. I'm Dr. Ezi, and I'm so happy to help you to pass your exams. And I will see you in another station. Okay? So see you later. Thank you very much.